In CLL, there's a very important role for genomic testing or genetic testing, and that's actually a couple of different tests that are now important. IGHV mutational status, which is very hard for patients to understand sometimes because mutated is actually the more normal state in that case. As B cells undergo somatic hypermutation, then there's actually there's other mutations like TP53 mutation that matter, and then chromosome changes, which are a different type of genetic change. Either structural changes in the chromosomes you see on karyotype or fish panel testing. So I think it's really important for patients to, if they're able to understand and want to, of course, understand these tests, because it really can predict how long people might go before needing treatment, response to treatments, what treatment might be most appropriate, expected duration of benefit from treatments. Usually when I share those results with patients, the first thing I do is make it clear that the tests we did are genetic changes in the leukemia or in the CLL cells, because so often the second you say the word chromosome or talk about mutation or genetic change, patients can assume that that's like an inherited change that they got from their parents or that they'll pass on to their kids. And I get questions, does everyone in my family need to be tested for deletion 17p? So the first thing I do is just make sure they know that the testing we did is only on their leukemia cells and that we're unlikely to find any genetic changes that would have any implications for family members. And then beyond that, I usually break it apart into kind of category of change, explain, what the change is or what it's called in a way that I think the patient can understand at their particular educational and communication level. And then also explain the implication of this change. So in terms of things like fish panel testing, if someone has deletion 17p, I'll share, that this is loss of part of a chromosome just in the cancer cells, and that predicts kind of a higher risk CLL with shorter remission durations or potentially worse response to therapies. Back when chemoimmunotherapy was used, that was very important because chemoimmunotherapy does not work very well all in that group, and targeted agents do. And then, if it's a chromosome change like deletion 13q, you would explain like what part of the chromosome is missing, and then also the implications of this being a favorable change in terms of predicting how the CLL cells behave. I think that also sets the stage for patients to understand that new genetic changes in the CLL cells can be acquired over the course of their disease. So you might say, like, these are the genetic changes in the CLL cells now, but as the CLL continues to exist in the body, it can acquire new changes, including some that can help it escape drugs that the patient might be taking. So I think it is sometimes an overwhelming conversation for patients that can include more science than they're used to. And as someone that loves doing research in CLL too, I'm always usually excited to share information. So I think anytime you're talking to patients about this or anything else, it's important to try to get a sense of how much information they want about this, what their level is for understanding, and also their desire to know more about this or not, and kind of what they're capable of understanding.